Uh, I hope you can hear me. Uzair, can you hear me?
Yes, sir, we can hear you very well.
Thank you very much for all the participants and for today's echo session on another vaccine. आजकल तो आप सब लोग कोरोना की वैक्सीन के बारे में जा रहे हैं, तो आई एम श्योर आप you have a lot of information on COVID vaccine. So we will be talking about a vaccine which is recently introduced in Pakistan and is now available commercially. I'm extremely grateful to our team who have put up a lot of effort for this program. And we are honored to have Professor Altaf Saab with us. And who else can we need to speak on this topic? So I'm sure we have a lot to learn in this session. Kiran, do you have anything to tell about echo sessions in general? If you
Yes, the standard announcements that we are going to mute everyone for a time being. So just to get a disciplinary session, and they can unmute themselves, and then they can ask the questions, or they can use the chat box as well. And we are part of a global movement called Project Echo, based in Albuquerque, USA, and our objective is to disseminate knowledge and best practices. The CME credits are available. You can contact Uzair for the credit CME credits as well. So I think these are the standard announcements, Dr. Asad.
Yeah. Thank you. And moreover, one more thing that now we have been asked to tell everybody that this session will be recorded. And once you join this session, so it automatically you give the consent for recording of this session, and later to be aired on the our YouTube channel also. So I think without saying anything further, the Professor Altaf Alam does not need any introduction. He is a professor of gastroenterology and hepatology, and he has retired from the post of head of department, gastroenterology department from Sheikh Zayed Hospital, and currently he is working at Evercare Hospital in Lahore. Also, this session is in collaboration with Pakistan Society of Hepatology. Pakistan Society of Hepatology and Project ECHO are now they were working before, but now we have planned a series of sessions on related topics, especially related to hepatology, and inshallah you will be seeing this every fortnight at least. Professor Altaf Sahab, I'm not going to take the time because we'd like to hear from you, and then we will be open for question and answers. Thank you.
Thank you, Asad. I'll share my screen now.
We can see the slides now. Yes.
Okay. Can you hear me all right?
Yes, we can hear you.
Okay, thank you. So let's start. The topic allocated to me by our director, Asad Saab, is HEV vaccine, why, whom, and how to vaccinate. This has recently become available in Pakistan, so it's right time to talk about it. This session is in collaboration with Pakistan Society of Hepatology and Parsa Echo Pakistan. And I will start now. I have no disclosures to make. This program is not funded specifically by any pharmaceutical company marketing the vaccine, and there is no speaker fee involved. So I will talk about academics and not about the marketing of this product. I would like to acknowledge that I will be sharing some slides from Professor Ting Wu and Dr. James Shi for Xiamen, China, with permission. I bring greetings from my hometown, Lahore, to all the participants all over Pakistan and around the globe. So the first question that I'm going to answer is there a vaccine for hepatitis E virus? Well, the answer is yes, now it is born, at least in Pakistan, recently. This was initially called HEV 239 vaccine, which after a randomized controlled double-blind phase 3 trial in China is named Hecolin. And the dose schedule used in this trial was 30 microgram per dose, given at 0, 1, and 6 months, just like hepatitis B. There was a control arm where hepatitis B vaccine was given 5 microgram per dose. There were more than 100,000 healthy adults participating in this trial, phase 3 trial, aged 16 to 65 years. So this trial is basically from 16 to 65 years. And male to female ratio was 1:1. The data is now published in 2 landmark papers, in Lancet in 2010 and in New England Journal of Medicine in 2015. This is the world's only vaccine against hepatitis E. The process started way back in 1998 when the program was initiated by NIDVD in China. Following preclinical phase 1, phase 2, and phase 3 trials, which completed in 2009, this vaccine called Hecolin was launched in China in 2012. In 2016, registration was filed in Pakistan. Site inspection by DRAP Pakistan was in 2018, and final approval was granted in Pakistan by DRAP for Hecolin to be used in the real world in 2020. And it has become available recently in 2021. So this is the timeline for the initial trials and the approval process. Hecolin, as I mentioned earlier, is a 30 microgram HEV 239 protein taken from genotype 1, but as all genotypes have just one serotype, it is expected to be effective against all genotypes. This is E. coli expressed viral-like particles. And the trial that I talked about, the phase 3 trial, was in people more than 16 up to 65. It comes in 0.5 ml suspension in pre-filled syringe and can be stored at 2 to 8 degrees centigrade, which is the normal refrigerator temperature, for 3 years, 36 months. So it has a good storage timeline. for at least 5 months with efficacy of 100%. Later on, in 2015, there was another follow-up publication by Zhang et al. For long-term efficacy of this vaccine up to 4.5 years. And as you can see, both with modified intention to treat and per protocol analysis, the efficacy was 93% and 87%. So up to 5 years, 4.5 years, the long-term efficacy against clinical hepatitis E was 93% on per protocol analysis and 87% in per protocol and modified intention to treat analysis respectively. The vaccine efficacy remained high for at least 4.5 years. So this is what was the highlight of this publication. There is unpublished data where up to 7.5 years analysis has been carried out, and it shows that both with modified intention to treat and per protocol analysis, the efficacy remains 87%. So this is quite good. And according to a mathematical model that has been created, it has been shown that majority of people remain protected for up to 30 years. So it does work in the long run, but the data is only up to 7.5 years so far, with 87% protection. In China, where this trial was conducted, there are a lot of hepatitis B carriers, and immunogenicity of hepatitis E vaccine in healthy hepatitis B surface antigen carriers compared to Hep B surface antigen negative population was very good. As you can see, the antibodies, the immunogenicity of the vaccine was good in both groups, whether surface antigen positive or negative, and hence it can be used in chronic liver disease, which is a suspect population, as we will see later on. The efficacy was good even in those with baseline HEV IgG positive or baseline HEV IgG negative. So just like COVID vaccine, you don't have to check for the status of hepatitis E IgG before giving the vaccine, because it works very well in both groups, whether you have baseline IgG positive or not. Just like COVID, the natural infection does not produce long-lasting or robust immune response. Hence, vaccine for hepatitis E, even in those with history of HEV, may be given just like COVID. So in summary of these publications, the vaccine is efficacious. It is well tolerated. Most adverse events were mild. Serious adverse events occurred at similar rates between the vaccine group and the placebo, and none of the serious adverse events were considered to be related to the vaccination. So this is good news that it is not only efficacious, but also safe. A lot of work has been done since marketing in China in 2012. And the long-term efficacy of Hicolin, safety or immunogenicity of Hicolin in healthy volunteers aged over 65, the study of this vaccine in patients with chronic liver diseases, and evaluation to protect the pregnant women in rural Bangladesh and the risk factors for where there are risk factors for severe hepatitis E infection. This is ongoing, but the rest of the studies have finished. Also, the study, the safety and immunogenicity of Hicolin co-administration with hepatitis B vaccine is also finished. And the data is awaited. Safety and immunogenicity of Hicolin in an accelerated schedule. As you know, the standard protocol recommended by the phase 3 trial is 0, 1, and 6 months, but the accelerated schedule is 0, 7, and 21 days. This will particularly be useful in an epidemic situation where there are a lot of patients being reported from a particular area, and to protect the rest of the population, you can give vaccine in an accelerated schedule, not waiting for 6 months to complete the vaccine. This is a good move because certainly this will be the need of the hour, where you get a lot of infections and epidemics from time to time. So this is the study that I was talking about. Effectiveness trial to evaluate protection of pregnant women by hepatitis E vaccine in Bangladesh and the risk factors for severe HEV infection. It is a randomized controlled double-blind trial conducted on healthy women aged 16 to 39 years. At the time of induction, it is required that these patients should be not pregnant. And those who have missed their period will be offered a test to confirm whether they are pregnant or not. The schedule remains the same: Hicolin or hepatitis B vaccine as a placebo at 0, 1, and 6 months. More than 20,000 people, young females, have already been enrolled, but as the follow-up period is up to 2 years, the data is not out yet. The purpose of this study would be to see the effectiveness of hepatitis E virus vaccine in preventing HEV disease during pregnancy among women in rural Bangladesh. And the sponsor is Norwegian Institute of Public Health. So this will be a landmark trial which will tell us that how effective this vaccine would be if given to females before they become pregnant, fertile women, potentially fertile women before they get pregnant. As I was talking about, there is data now about the accelerated schedule of HEV vaccine. And as you can see, whether it is given at 0, 1, 0, 7, and 21 days, or the routine 0, 1, 6 months efficacy at 1 month after the last dose of hepatitis E is 100%. So this is just a preliminary data because follow-up is going on, and we will know later on whether the accelerated schedule works in the long run as well, just like the routine schedule. This is what tells us that the immunogenicity of the vaccine is good even with accelerated schedule given at 0, 7, and 21 days in blue color here. And it remains above the protective level, which is considered to be 1. So it works in accelerated schedule, which can be given in epidemic situations. Now the question arises, why to vaccinate for hepatitis E? We all know that hepatitis B vaccine is around for many years, and we are vaccinating for it and trying to cover as much population. But let's look at the data as to why should we vaccinate for hepatitis E. Hepatitis E is a leading cause of acute viral hepatitis globally, particularly in Asia, Africa, and Middle East. And the majority of the patients with acute hepatitis here fall in the category of hepatitis E. If not majority, a large proportion of patients fall in the category of hepatitis E. And every year, there is an estimated 20 million HEV infections worldwide, leading to an estimated 3.3 million symptomatic cases of hepatitis E and 56,000 hepatitis E related deaths, as well as 7,000 stillbirths. When it occurs in the last trimester of pregnancy, it plays havoc. And we all know that. There is a lot of data to suggest that in the last trimester, acute hepatitis E causes 16 to 25% mortality and high rate of stillbirth. Moreover, there are a lot of epidemics reported worldwide, particularly in Africa and Asia. In Pakistan, there have been outbreaks in Karachi and in Islamabad, in addition to minor outbreaks at other places. So no place is immune, and epidemics keep on occurring every 3 to 5 years in all these places. When we investigated an outbreak of viral hepatitis in Karachi, and this was published in Journal of Medical Virology, our colleagues from Aga Khan were mainly involved in this study, and it showed that almost all patients were due to hepatitis E. And in all these people, we had genotype 1. So in Pakistan, we know that genotype 1 of hepatitis E is the predominant virus. There is also a fear that if your patients with chronic liver disease due to any cause develop acute hepatitis E, they don't do well. And there is data, not only one, but another study that I have come across by Dr. Lubna, published in Ayub Medical Journal. This study from, again, Aga Khan group has shown that if you have chronic liver disease and you get superinfection with HEV, it can cause hepatic decompensation, leading to increased morbidity and mortality. The large majority of CLD patients in endemic countries are vulnerable to infection with HEV, but are protected from hepatitis A, as most of the adults in the developing countries have been exposed to hepatitis A and immune from repeated attacks. As you know, in hepatitis A, repeated attacks are very, very rare. And although there are numerous case reports in the literature, but generally speaking, hepatitis A, you get it once, whether clinical or subclinical, it leads to long-term immune status. And such people with chronic liver disease are ideal candidates for HEV vaccine, because you can reduce morbidity and mortality if they get hepatitis E, and you want to prevent that from happening. A brief word about hepatitis E virus. It belongs to Hepiviridae family. It's a non-membrane RNA virus, 7.2 kilobase in length, and contains 3 open reading frames. Open reading frame 2, or ORF2, encodes a single structural protein of 660 amino acids containing neutralizing epitopes and is the target for vaccines. The HEV vaccine is a recombinant vaccine containing 239 amino acids of open reading frame 2, adsorbed to aluminum adjuvant and thiomersal as the preservative, as I have mentioned earlier. Now we know that there are 8 genotypes of hepatitis E. 1, 2, 3, and 4 are of significance to human beings. 1 and 2 are human specific, while genotypes 3 and 4 are zoonotic, with swine as the main natural host, but they can transfer to humans and cause disease, either acute and chronic. Fortunately, the 4 genotypes of HEV have only one serotype. So it is expected that if you Hicolin or hepatitis E vaccine that is available to us will be effective against all 4 genotypes. But this is yet to be proven in clinical trials. The other genotypes, 5, 6, 7, and 8, are not important to human beings, and they are seen mainly in animal species. Another important point I would like to highlight that genotype 1 and 2 do not lead to chronic infection, unlike genotype 3 and 4. As you know, immunosuppressed people, if they get exposed to genotype 3 and 4, they develop a chronic infection state and accelerated cirrhosis unless you treat that. But genotype 1 and 2 do not have this property. So in Pakistan, we do not see chronic hepatitis E because our predominant genotype is genotype 1. Moreover, there are a lot of other extrahepatic manifestations that have been described in hepatitis E. All these are specific to genotype 3 and 4 and not to 1 and 2. So these are minor differences which are worth remembering while you are dealing with patients with hepatitis E. Most of the patients that I have seen with severe hepatitis E, and if the hepatitis E viral test was available by the time they presented, majority of patients were already negative for HEV RNA. But in some who were caught early, HEV RNA was positive. So the role of treatment by either ribavirin or even interferon for chronic sequelae of hepatitis E is probably not warranted in our country. How to vaccinate? Well, the standard schedule is 30 micrograms, 0, 1, and 6 months, 0.5 cc in a pre-filled syringe stored in a refrigerator for up to 3 years. Rapid schedule, there is limited data to suggest that it works, and 30 micrograms should be given at 0, 7, and 21 days. But this is limited data, and more work and long-term follow-up of this schedule is not yet available. As far as we know, this vaccine is effective against all genotypes which are important to human beings, 1, 2, 3, and 4, as HEV has only one serotype. I've already shown this slide that rapid schedule works, and in a short-term follow-up, almost 100% in both routine and accelerated group immunogenicity was obtained. So I've already talked about this. Now the $1 million question is whom to vaccinate. We know now we have a vaccine, it works, it is safe, but whom to be given? Well, these things are very clear that women in childbearing age, so that when they get pregnant, they do not suffer the bad effects of hepatitis E, particularly in the 3rd trimester. Chronic liver disease patients, the data is available from China. The study has already been completed. It works and it prevents acute hepatitis E in such category of patients. And this is a large chunk of our patients who could benefit from this vaccine. Immune compromised patients and organ transplant recipients, particularly where genotype 3 and 4 is dominant, particularly in the West, they can be protected from acquiring hepatitis E and progressing to chronic liver disease due to hepatitis E. Elderly, because we know if you get hepatitis E in the old age, they don't do very well. So again, this is a target population. Emergency outbreak settings. Here, one has to look for the results of efficacy of rapid schedule. And if it works, this will certainly be worthwhile, giving 3 vaccine, 0, 7, and 21 days to protect the unaffected population so that they do not get affected by the outbreak. Healthcare personnel, particularly those lab personnel who work with viruses, and travelers to endemic areas as another target population which can be vaccinated to protect them from hepatitis E. General population in endemic area, so just like vaccinating everyone. With the currently available data, we could only recommend that more than 16 years of age and non-pregnant females, the whole of the population can be considered for vaccination in endemic areas like in Pakistan. Another $1 million question is, can the pregnant women be vaccinated? You know very well that these are susceptible group of patients who, if get hepatitis E, particularly in 3rd trimester, will go into acute liver failure and will not only die in large numbers, but will have an adverse fetal outcome. So this is the question, is HEV vaccine safe in pregnancy? The answer is not fully known, but in the phase 3 clinical study from China, 37 pregnant females were given 53 doses of vaccine inadvertently. It was not planned, but either they became pregnant later on, or it was not known at the time that they were pregnant and they were given the vaccine. And in all these vaccinated pregnant females, only one adverse event, and that too, local injection site reaction was seen. So as far as we know from this phase 3 trial, it was considered safe in this small cohort of pregnant patients who were inadvertently given the hepatitis E vaccine. There is another data in literature where human papilloma vaccine was given to females, again, adult females, to protect from cervical cancer. And Hicolin was served as a placebo control. And this is published data in JNCI last year. Of these patients who were given HEV vaccine, around 1,000 became pregnant. And as you can see, the adverse events like spontaneous abortion, stillbirth, maternal complications were about the same as you would expect in normal population. So this is not an ideal study to quote for the safety of, because this was not the intended purpose of this study, but some data to reassure that it is probably safe in pregnancy. So after all this, should HEV vaccine to be administered during pregnancy? The data available so far is sparse, and such recommendation, of course, cannot be made across the board. Attempt should be made to vaccinate women of childbearing age before pregnancy. But we forget this, that in antenatal clinics, counseling on the importance of clean water and clean food is not emphasized as much as it should be to protect pregnant females from getting hepatitis E. In rare cases where benefit of HEV vaccine outweighs risk of vaccination, it may be given. Who are these? We'll talk about it from our gynecologist colleagues, if there are any. No need to terminate pregnancy in case of inadvertent vaccination in pregnancy unless wished by the family. But I would certainly not give them the second or the third dose because the data is not available. And certainly, as I mentioned, would welcome our gynecologist colleagues, if there are any, on the matter when I finish. Is HEV vaccine safe in elderly? As I highlighted, elderly don't do very well if they get acute hepatitis C. This is a study which has already been completed in China, and around 200 people over 65, when compared with those who were less than 65, the immunogenicity was good, approximately same, around 97 to 99% in the short term. This is only short-term data that we have. So and it was safe as well. As you can see, there were no significant adverse events in this elderly population. So the conclusion of this study was Hicolin is immunogenic and well tolerated in elderly people aged greater than 65. How can you get HEV vaccine in Pakistan? Now it is available. How do you get it? You have to contact your local Firozson's representative. It is not available in pharmacies. This is to ensure post-marketing pharmacovigilance, because the data, we want to include all these people who get this vaccine into a phase 4 trial to see the efficacy and safety. And this can only be done if some organization is following them up, and this can only happen if it is through an organization rather than through the fish market. So this is the way you can get it. It is available, you can get it. And if you want to prescribe to your patients, women in childbearing age, suspect population in general in endemic areas like in Pakistan, you want to vaccinate people with chronic liver disease, you need to contact your local Firozson's representative so that they can provide you the vaccine and also ensure that the patient is followed up in the long run, so that the efficacy and safety is continued to be monitored. So I'll stop here and we'll be happy to take any questions. So in summary, the recombinant HEV vaccine is safe and highly immunogenic. It could substantially decrease the infection risk and effectively protect the vaccine receivers against hepatitis E. The vaccine is recommended for adults older than 16 years who would be at high risk of HEV infection or who might suffer more severe consequences after HEV infection, such as people with underlying liver disease, women of childbearing age, travelers, or people living in HEV endemic areas like in Pakistan. Thank you very much for your patiently listening. So I'll stop, share, and we'll be happy to take questions if there are any. Thank you very much.
Thank you very much, sir. A wonderful talk. And over to Zishan to carry on with question and answers. Zishan.
Thank you, Asad. An excellent talk by Professor Altaf as usual. Very informative. There have been few questions. Most of them have been actually answered during the talk but these are important. So it would be good to re-emphasize. I would just go through the question and have the answers from Professor Altaf. The first one is the accelerated schedule applies to those who want to travel to endemic areas.
Yes, so this is for in an outbreak situation and for people who want to travel at a short notice. Yes.
And then there is this vaccine genotype specific, or it can be used across all genotypes. Again, that probably was answered in some of the slides.
And we think it is going to be effective against all 4 genotypes. in China, they have genotype 3, 4, 1, and 2, all 4 genotypes. So it is protective against all 4 genotypes in China, but we need to prove this point that it is specifically effective against genotype 3 and 4. And NIH in USA has started a phase 1 trial to prove this point. So certainly we'll get the.
Excellent. Now, the next question is about the pregnant woman. Probably it was very answered in detail. It was asked prior to that it is not being tested and data is not sufficient enough. Then what investigations are required before vaccination?
None. Basically, just like COVID vaccine, you don't take a series of 100 tests with you. For vaccination, the purpose will fail if you give the patient 100,000 rupees worth of investigations prior to vaccine. The only thing is that you have to ask the females about their last menstrual period. And if they have missed the last menstrual period and practicing unprotected sex, then certainly a pregnancy test is in order. That's all. Thank you.
Can this vaccine be used in chronic liver disease patient?
Yes, the study has already been conducted in China. It is safe, it is immunogenic, and this is the population which is certainly likely to benefit most in our country because we have a large chunk of chronic liver disease patients. Yes.
I would just add on, this is one of the population specifically we should be targeting to vaccinate, because acute and chronic liver disease is very frequent when they come across with hepatitis E, ACLF, and we see in being as a tertiary care hospital, a lot of patients with ACLF reported secondary to HEV infection. So we should prioritize our patients with chronic liver disease and cirrhotics for HEV vaccination. So the next question would be, can vaccination hepatitis B and E vaccine be given at the same time?
Yes, it has already been done in China, and it is unpublished yet, but both vaccines can be combined and given together. Yes.
Again, the question of teenager has been answered very in detail, that 16 and above, it has been licensed. And can the patient with previous history of HEV be vaccinated?
Yes, just like COVID, you don't need to ask this question. Go ahead and vaccinate, because I've shown the data that whether HEV IgG is positive or negative, it works well and is expected to produce more robust and long-term protection than the natural infection, which wanes in time and one can get repeated attacks of hepatitis E.
Now comes the most tricky question. Can HEV vaccination be given to the population at risk who were vaccinated with COVID vaccine?
Certainly, there is no problem with these. You get many vaccines anyway. You get flu jab, you get pneumonia vaccine, you get hepatitis B vaccine, you get typhoid vaccine, and in the EPI program, you get multiple vaccines in one go. Even you have a pentavalent vaccine, so why not? Certainly, I think there should be no problem with that.
We probably have a raise hand as well by Dr. Ikram Raja. We'll take question from him and we'll back to the few questions in the chat. Dr. Ikram, Uzair, can you unmute Dr. Ikram?
So it's always wonderful to listen to you for the excellent talk. Sir, you mentioned about healthcare personals. Please a little bit elaborate about them, that who is the real candidate for this vaccine?
Well, they are mainly those, well, all healthcare workers are more prone to get hepatitis E vaccine, are more prone to get hepatitis E infection, but particularly those who are working in labs and handling specimens positive for hepatitis E, those who are working in the wards and, uh, looking after patients, their secretions, their feces, etc. All these people are at increased risk of hepatitis E. So healthcare workers, but particularly those lab workers who work in the virology department and work with infectious material are should certainly be considered for vaccination.
Excellent, sir. Then there is another good question from Dr. Fakhr. Though there is no data for post-transplant patients, given the mechanism of action, do you think it would be safe in post-transplant setting or immunocompromised patients?
Yes, in this category of people, the only advice is don't give live vaccines, and we avoid that. So you don't give polio drops to post liver transplant patients. You give the injection form, which is inactivated virus. So the same principle applies here. This is not a live virus. This is not an attenuated virus. This is a genetically engineered 239 amino acids from open reading frame 2 expressed by E. coli. So it is a virus-like particle. There is no active virus in the vaccine.
The next question is, should all women with childbearing age should be vaccinated?
Yes, this is the main purpose of this study from Bangladesh, that this is going to highlight the population there in rural area, which has been targeted, is at a very high risk of hepatitis E infection. And the purpose of this study, enrolling more than 20,000 females, is to see how good it can prevent hepatitis E infection and related mortality in pregnancy. But there is no doubt that this is the ideal population to vaccinate women in reproductive age group. So they are the best candidate, along with chronic liver disease people and elderly population, to vaccinate for hepatitis E.
Now the question is there any data in pediatric population?
No, there is no data, and a study is planned but has not even started in starting from China. So there is no data in children less than 16 years so far.
Can Ecolin be given an accelerated dosage in pregnancy?
Generally, this is not the need. One, it should not be given in pregnancy. But if you consider high risk, and if we have any gynecologist, we would welcome their opinion. What is this high risk? If you have a high risk pregnant female, the standard schedule will suffice, because after 2 doses, you get almost 100%, as I've shown data. 0 and 1 months get 100% protection.
Can a patient with acute hepatitis A or B be vaccinated for HEV? Or we have to wait for the resolution of acute hepatitis?
Generally speaking, one should not be so adventurous, and in sick people start vaccinating for illness which has not occurred, which is theoretical, which may never occur in their lives. So it is certainly not a good practice, I would say. I would never do that.
Next is, can a patient with IBD or immunocompromised patient be vaccinated?
Yes, as I mentioned, this is not a live vaccine, so no problem.
So that probably ends the most of the questions which were in the chat. I would just add on, sir. I was in discussion with one of our gynecologist colleague, and they were of there was a question put up by. Unfortunately, none of them have actually joined. I tried to get them on board for today's talk. That what a recent trend we are seeing, and that I agree with her opinion, that most of our acute hepatitis E patients, pregnant patients, even developing acute liver failure, are getting better. And that's what her opinion was. In last 2 or 3 years, the outcome of hepatitis E has been excellent. There has been rare mortalities, though earlier reported very high mortalities. So she was of opinion that what is the risk against the benefit, cost effectiveness of a vaccine, or vaccinating a whole population of childbearing age in a vaccine resistant population. And then would it be cost effective to vaccinate such a huge population? That is, we have got 50% of the female population, and most of them are young as well. So that is the, do we have an outcome data of HEV in pregnancy in Pakistan in last 2 3 years, which is suggesting that a lesser adverse outcome?
Well,
Yeah.
anecdotal data does not carry any weight, so we have to prove it in large number of pregnant females, the outcome studies. So, but even then, hepatitis E does occur in endemic areas. We all know that. We all see patients with hepatitis E regularly, whether pregnant or not. So maybe we are vaccinating for hepatitis B as well, so why not protect the population from hepatitis E? Many of parents are now coming to me for getting vaccine for hepatitis A, and fortunately when I check them for antibodies, they are negative, so they have not been exposed yet. So I advise them to get vaccinated. So it's not compulsory, but it's not going to make it into an EPI program, but certainly something to, if you have it, it's good, and you can vaccinate the population you think should.
Thank you.
Another question about lactation.
No problem has ever been documented with hepatitis E vaccine because it was never given to pregnant women. So we don't have this data. If the with a vaccine not having a live virus, I don't see any problem there. So for lactation, it should be.
Thank you, Zishan. I can see a lot of senior gastroenterologists here. Dr. Altaf Naqvi, Arshad Kamal Bhatt Saab, Shamail. So I may be missing some names. So we will be winding up this session. I would like to have comments from Javed Iqbal Farooqi Saab, and to finish the final words from Professor Kashif Malak, who is also the president of Pakistan Society of Hepatology. So Javed Saab, Javed Iqbal Farooqi, if you can unmute yourself and say a few words, and then.
Thank you, Dr. I congratulate for having such an excellent talk. And again, another talk, the beautiful one, the great one by Professor Altaf Alam. I think it was a very, very elaborated, and it explained all the aspects, all the questions which come in mind. And I hope in the days to come, we will experience more about this, and we will learn more about this. And definitely our cirrhotic patients who are at the risk of the ACLF, and when we don't have that free access to the liver transplant, I think this is a great milestone, and it will be a great remedy for these patients. Once again, I congratulate you as well as Professor Altaf Alam for this an excellent scientific activity. Thank you very much.
Thank you. Dr. Kashif, President, Pakistan Society of Hepatology.
Assalamu alaikum. Thank you, Asad. Thank you very much. It was a really, very nice talk as usual by Dr. Altaf Alam, and we learned a lot. And I just offer all the participants, if somebody is interested to doing some study on hepatitis E vaccination, we can do a multi-centric study under PSH logo, and as well as the Sheikh Zayed Hospital can take lead in that. and we can make a multi-centric study in maybe the normal childbearing women and normal adults, or maybe in the pregnant ladies. So the offer is to all the participants, if somebody is basically interested in that, they can use the platform of ECHO as well as the PSH, and we can make a good study to present our own data to the world. Thank you very much.
Thank you. Thank you, Kashif. To all the participants, inshallah, in a couple of weeks' time, we are going to have a session again in collaboration with Pakistan Society of Hepatology on liver disease and Ramadan. So if you have any question about liver disease and Ramadan, if you can just send them to Uzair or to myself, so that I can request the speaker to take up those questions in the talk. So we again want to make it an interactive and before Ramadan. So this will be a nice session for all the practitioners. Professor Altaf Alam, I'd like to thank you again for your time and for an excellent, wonderful talk. I am grateful to our PARSA ECHO team. Kiran is administrator, Uzair coordinator, our IT person Haris and Salman. Dr. Amna is probably here somewhere because there are a lot of participants. So they have done a wonderful job. I'm also thankful to Ferosans, not because Ferosans has actually launched Hacolane in Pakistan, but their association and their support for this program has been immense for the past couple of years. So I would like to say goodbye because it's about to time, and inshallah we'll be meeting again in a couple of weeks' time. Thank you very much all. Uzair, over to you.
Thank you very much, sir. Till next time, Allah Hafiz to all of you.